Well, although it's the first day in the Congress, it's still a late hour. Today we're going to talk about childhood anxieties and how they evolve toward adulthood from a rather practical point of view. Anxiety disorders are important because they are one of the diagnoses that are mostly overlooked. I'm not going to read from this list, but anxiety disorders is one of the group of diagnoses which has been modified the most frequently. There's been a lot of changes over the years. Maybe some ages were changed. What has changed? First of all, it has been grouped under three different headings, and obsessive compulsive disorders is now defined as a separate disorder, and more importantly, trauma-related disorders has been reorganized as an entirely separate group. And in anxiety disorders, there was a heading about those which are seen in infant period and childhood period. It's important because separation anxiety and selective mutualism is also seen in adulthood, and DSM has finally acknowledged this because these are prolonged diagnoses. Or even if we change their names, this is indeed separation anxiety, and when you look at the higher groups as well, we can see it in the young and adulthood group as well. So I think it's good that they took it out of the infant and child group. So this is another change in the DSM. Therefore, avoidance of school and work is now assessed as separation anxiety. What is the only difference? In adults, it has to be present for 6 months or longer. This is a new criterion because avoidance of school or work or street caused by other factors should be excluded. Social phobia was a very common term, and the DSM said we should be using a social anxiety instead of social phobia. And also selective mutism was not classified under anxiety disorders. It is now in this group. And as I said, DSM has introduced many changes in anxiety disorders over the years. Anxiety disorders are very important because clinically speaking, they are really rarely diagnosed, but still they are one of the most common disorders during childhood years. Also, it may cause a lot of confusion in diagnosis. Looking at of course, the prevalence may vary depending on studies or the selection criteria, but it varies between 6 to 20%, but it's still significant. Rate of diagnosis is very low, and anxiety disorders can be mistaken for other conditions, and since diagnosis rate is low, of course treatment rate is also low. So we need to consider anxiety disorders so that you can diagnose it. Asking Vahdet, our co-chair, because it was his PhD topic. So we need to think of anxiety disorders, but usually the case is we're focusing more on other conditions, and anxiety disorders has symptoms which are similar to those of other conditions. One of the main reasons for this is that children are unable to define anxiety. This is true even for adults, and it's difficult to define anxiety even in adulthood. Everybody comes up with different names, but this is even more difficult in children because no child comes to you says I am anxious, and so it's difficult to name and define that negative feeling negative emotion for them. And since they cannot define it, the clinician can overlook, and also on the part of the family, if this has not turned into a serious problem, like a refusal to go to school or not talking to anyone at all, the families are not able to detect or communicate anxiety to the doctors. That's why it's a very common condition. The term anxiety is controversial not only in our country but also around the world. Actually, there are other words which define anxiety much better, especially in the children group. For example, the families, they use the word sensitive, saying my child is very sensitive, would often feel sorry for others. So if a child is unquote sensitive, then we should be checking whether there is anxiety. Also, a lot of worrying or also shyness can be important in terms of diagnosing anxiety. Also, introvert or anxious or afraid, or maybe these kind of terms may all be related to anxiety, so we should keep those in mind. So, onset age is very important in anxiety disorders. As I said, since its symptoms are similar to many other diseases, and since anxiety can be a symptom of other diseases as well. Maybe we are not talking about primary anxiety, but maybe it is a comorbidity along with HTDH, or so it's very important when the symptoms are first starting. Also, of course, there are children that are presenting to clinics with a different diagnosis. Maybe not in autism, but also anxiety disorder is often mistaken with ADHD, and but as you know, these kind of disorders are more common after puberty, but anxiety disorder is more common prior to puberty, and the rate is 6 to 20% prior to puberty. Therefore, it's also not very difficult to make a differential diagnosis with autism and ADHD. Well, of course, there are many subheadings under anxiety. There are different kinds of anxiety disorders, but they all have some common characteristics. One is overstimulation, or another one is a reaction to new stimulants, and maybe threat bias, and as a defensive mechanism, avoidance of everything that could cause anxiety, especially in children in schools before puberty. This is one of the most common findings. Catastrophic reactions. Things like, I can't do it, I won't do it, and the quitting. Parents typically support the fears and anxieties of children before puberty. When they do not make their children confront those fears and anxieties, it is defined as if anxiety was a part of a child's nature, and it is therefore overlooked. Well, of course, there are some physical findings as well, but these physical findings are confused by the family for some metabolic diseases, physical diseases. And this is how these symptoms are distributed across the body, and these symptoms are very easy to express in adults, but they become more vague in children. They turn into sentences like, my child can't swallow pills, or maybe can't eat very hard food, or maybe interrupted breathing, intestinal problems, tingling in fingertips, urinary problems. Intestinal and urinary problems, they usually end up with the family taking the child to a nephrology or a clinic. And I don't know if you have seen these cases, but there are a very high number of very young children who have been diagnosed with a reflux because of stomach pain and difficulty to digest. And so many of these are anxiety disorder symptoms, and when you treat anxiety disorder, those metabolic symptoms also disappear, so it's important to bear in mind. And we also talk about problems with falling asleep and in the middle of night awakening, and there is also eating problems, overeating and undereating, like in many other disorders. It's very difficult to get this history from the family in childhood group, and I've been doing this for a long time, and I've never heard of a child who has appetite, and all of the families keep saying that their children have no appetite. So we need to investigate thoroughly whether the child is overeating or undereating, because sometimes it may be caused by the mother's perception. Maybe it's undereating according to the mother. Also, excessive need for reassurance for even minor things, like asking, would their house be struck by lightning, or maybe when going to bed, is everything going to be okay? Is there anyone under the bed? Will I be safe? And these kind of symptoms, they can be misinterpreted as some natural findings, which is part of the development of the child. But we need to investigate what is the significance of this in order not to mistake them for age characteristics. Another thing that's most problematic in the clinic is inattention and poor performance at school, and sometimes attention and deficit hyperactivity disorder can cause more problems than anxiety disorder. And sometimes the child, if the parents are saying, my child is very clever, but is failing because of a lack of attention during classes or during exams. So we should always consider anxiety disorder and evaluate the other findings as well. And this is something I see most often, and there are a lot of children who are suffering from anxiety disorder but have been diagnosed with ADHD. Also, explosive outbursts. We should always consider anxiety disorder with this symptom. Avoidance of outside and interpersonal activities. This is also common in anxiety disorder. Maybe school parties, camp, sleepovers, safe strangers are some of the conditions avoided by children, and they can be findings of childhood anxiety disorder. Also, another thing is none of these symptoms should be pervasive. I mean, just the fact that it's not happening all the time doesn't mean that we can rule out anxiety disorder.
Specific phobia is still there, and even if it is listed as a separate entity as a subheading in the DSM-5 classification list, it may not be prevalent in all the children that we're talking about, but with patients of anxiety who has obsessive compulsive disorder, specific phobia, OCD, separation anxiety disorder, generalized anxiety disorder, social anxiety disorder, and selective mutism is also usually listed under this heading. Acute stress disorder, post-traumatic stress disorder, and panic disorder are the symptoms that we can see in childhood, and they are quite important in terms of evolution into the adolescence and adulthood. Now, what about specific phobia? What can we do? I'd like to take a look. Specific phobia can be with regard to animals, with regard to insects, cats, etc. We're talking about environmental factors such as thunders or fear of heights. We're talking about fear of blood or injection. And we're also talking about situational phobia, taking an elevator, going into a tunnel, for example. Now, the fear of the elevator, fear of the lift, is a very common one in childhood, and some phobia may be misinterpreted and may not even be mentioned, as we think that children are already afraid of such issues. So when we don't question them, interview them, we could just skip them and miss them. Now, looking at the anxiety issues in childhood, specific phobia is not really common or pervasive, but when we take a look, it might also include one of the other subgroups, up to 70%. Now, phobias are expected to go away as the child ages and goes into adolescence and adulthood, but that does not happen in these children, and we see that specific phobia are the most commonly evolving and transferred phobia and anxiety disorder that go from childhood to adulthood. In particular, when it occurs with panic disorder, the rate of continuity is very high. In childhood, presence of any specific phobia and any anxiety disorder for adulthood may be correlated. It's an important risk factor. So, for preventive measures, childhood phobia need to be studied and coped with. Separation anxiety disorder is also one of the very common anxiety disorders. We're talking about excessive concern regarding separation from home or from the figures of attachment in the house. And these are actually some sort of anxiety that is triggered by the parents sometimes. And parents also feel that something bad might happen to the child, and that might trigger this disorder. Therefore, the child may believe that bad things might happen to himself or herself or the parents, and does not really wish to be alone. And we also see that in situations where the child needs to be separated from the parents, we see that they try to avoid such situations. Falling asleep or sleeping alone might become an issue as well. And also, generally speaking, in separation anxiety disorder, parents, we know that this is a sort of anxiety that parents really succumb to. and we see that it continues at about 16% to adulthood. In my clinical view, we see that the child comes in, you're very decisive, you just say, we're going into this room with you and your parents will wait here. And while you're taking the child away, mother or father might say, oh, he won't remain there without me. And that is exactly the word or the phrase that the child was waiting for. And then we end up with parents who are complaining about children who can't even go to the toilet without them. So you're actually triggering it yourself as a parent. So my view for adults, for university students, for example, age 24, 25, we see there's a huge amount of separation anxiety. And in the past, maybe we didn't coin it specifically. We saw dropouts or young people quitting or not attending the university that they have studied for is very common. And we see that separation anxiety, that's because why separation anxiety continues into adulthood. And we look at generalized anxiety disorder. We're talking about excessive worry and sort of being apprehensive. We're talking about restlessness. And we're talking about being on the edge all the time. And also, these children or youngsters usually complain about a constant anxiety at school causing fatigue. And they feel far more sluggish than other peers. And we also see that they have a lot of concentration problems during tests, and they believe they choke on them. And we see that falling asleep becomes a big problem, and their sleep duration decreases, which culminates in their lack of success in the exams. And as this happens, they start feeling or going into a vicious cycle, believing that they will fail in the following exam. So it becomes a sort of constant problem under the heading of generalized anxiety disorder. Now, going into sleep or falling asleep and other sleep disorders are also a big problem due to the concern and worry and apprehensiveness, and they feel really hard to control this concern or worry. And they show this, or they display this with their attitude and behavior. Sometimes they insist on something, sometimes they attack, sometimes they cry for a long time. And this might also cause severe dysfunction. Sorry for that. In adulthood, and we look at generalized anxiety disorder, we see that this continues deep into adulthood unless treated, and it continues as it is. And all studies done in adulthood with regard to the generalized anxiety disorder shows us that the children with generalized anxiety disorder usually end up with depression in adulthood. And when we look at the follow-up trials with children with generalized anxiety disorder, an Italian follow-up study shows that almost all of the children have received a psychiatric diagnosis in that decade. Therefore, anxiety disorder might evolve into something else in adulthood or might persist as anxiety disorder itself. Looking at other factors, we come up with social anxiety disorder that presents with worry for performance or worry in social relationships. And we see that children with this disorder usually do not want to lose when playing a game, and then when they lose, they react very vehemently. So parents might say, because we end up always losing it so that he or she is happy. And also the worry of performance is something that might be triggered by the families, well, which most families trigger it actually, by regulating their child's performance too seriously or by losing to the children all the time in a game environment or game situation. We also see that there's selective mutism. These sort of children prefer not to talk or speak in certain situations, and not speaking in social situations is a big factor. And also selective mutism, social anxiety disorder, also proceeds towards adulthood, and they are usually diagnosed with social anxiety disorder during adulthood. Panic disorder. Years ago, it was said that panic disorder is not prevalent in children because the child needs to have developed cognitive skills, and panic disorder might present itself with symptoms such as I will go crazy or I'm dying. So children cannot recognize and comprehend that, it used to be said. However, all those studies done since have revealed that we can see panic disorder in children. During attacks of anxiety, physical findings might be hyperventilation, the feeling of pounding or abdominal pain. During childhood, these symptoms do not really ring bells of panic disorder for the family and even for the clinicians. So most of the time, these children are referred to the pulmonology department or gastroenterology departments. As they are children, nobody suspects panic disorder. So with organic treatments, they are tried to be treated, and this is what the results tell us on a global scale. So panic disorder should be considered for diagnosis. And we see that it proceeds into adulthood with a rate of 44%. So these clinical findings, symptoms need to be evaluated. And looking at society-based follow-up for a period of 15 years, in this study we see that it proceeds 4% from childhood to adulthood. And also it's an important risk factor for depression and substance abuse in adulthood. In children with anxiety, we always know that there's anxiety. The anxiety is in place anyway. And we also see that it's always in backstage, and sometimes the symptoms might be triggered with some other events, life events, for example. Therefore, when you interview with the child and try to question the symptoms, you can understand that this can't be triggered by other reasons, life events or environmental factors, for example. So parents tend to minimize the impact of anxiety, usually saying, oh, this doesn't happen all the time, or that wasn't the reason for his failure in the exam. So children with anxiety also can have fun. We should not forget this. When we talk about children with anxiety, we're not talking about children who can't have fun. Parents adapting to this anxious situation also worsens the prognosis, because this actually supports the anxiety of the child, and then they don't go into a search for treatment. Now, avoidance is very common. For example, families sometimes say that, oh, he used to play basketball a lot, but he quit all of a sudden. Because what the child did there was, if I can't fully success in this, whatever that is, I should not do it. Therefore, if there is poor performance on a horizon in the mind of the child, then he quits doing that, which affects the prognosis very badly. And this defensive mechanism works only temporarily, and anxiety rebounds after a certain stage. And this also prevents, or prohibits rather, other coping mechanisms to come to the fore. Now, dropping out of school or evolving into severe depression also failing to remain in college, panic disorder, and also substance abuse might also be other impacts of this anxiety disorder. So anxiety disorder evolves and morphs into something different during life, but we see that for all the lifetime of that person, be it a child or adult, it causes a psychiatric problem. So how do we assess anxiety disorder? I've tried to underline this all the time so far. As in all psychiatric diseases, the first condition of diagnosis is making sure that we get perfect history of the patient. And there are also other assessment criteria that we use for anxiety. And there are other sub-criteria like CBCI. Also, behavioral assessment system for children, and also multidimensional anxiety scale for children. That's, for example, specific for anxiety. And we see that in Turkey, for childhood, as far as I remember, we only have one valid measure. But don't forget, measures do not help us, do not make the diagnosis. They help us to diagnose the patient. There are other scales from international circles. Two of them have been used very recently for screening and evaluation of anxiety disorders, even if it's not valid in Turkey. And we can download the child and parent form via the links you have just seen. What about treatment? Am I going too fast? Looking at the studies and our information on this issue, we see that the SSIRs and CBTs are rather effective in anxiety treatment. Placebo response rate is very low in anxiety disorder, less than 25%. And the most effective is combination treatment with cognitive help that moves the response rate up to 80% from 55%. Antidepressants work extremely well, and SSRIs are the first line of choice. A typical antidepressant should be considered second line, but the first line must be the SSRIs. The largest trial was the Child Adolescent Multimodal Anxiety trial. 488 cases were evaluated. For 12 weeks, combination therapy was applied to one group, and the other group was given only medication treatment, and the other group was only given placebo treatment, or placebo. And the results have shown that combination therapy resulted the best in terms of the outcome. SSRI plus cognitive therapy, and CBT resulted in 59%, and sertraline was administered in this trial, and its efficacy was 56%, and placebo efficacy was 24%. The younger the kid, the more efficacious the treatment, whatever that treatment is. So the earlier we diagnose the anxiety, the better the prognosis. Medication is pretty well tolerated in the children, but younger children also have more adverse or side effects. Now, looking at the dose here, do we have anyone in Turkey applying such a dose in children? 120 milligrams per day was the dose they went up to, and that was detected as the highest secure or safe dose. In SSRIs, in our researches, we don't really go up to those doses, so we are a little bit more mean, so to speak. Adjusting the dose is crucial because insufficient treatment might make things far worse. Adolescents also require environmental and psychosocial arrangements and rehab, along with cognitive adaptation. And in other anxiety disorders, unfortunately, with regard to them, we have very limited sets of data. Now, looking at SSRI dosages, we have lots of researches about them. What is the highest safe dose, was the question was asked. With fluoxetine, up to 40 milligrams for 12 weeks, and with regard to adverse effects, no problems or no complications were observed. With fluvoxamine, 100 to 150 milligram daily dose was applied. For sertraline, it was again 150 milligram in another trial. Paroxetine was used for 50 milligram, and duloxetine was used for from 30 to 120 milligrams in a daily dose. And as you can see, we see that the doses are higher than what we have usually applied so far in our practice. So these are the ranges of doses that have been used in these researches or trials. Now, SSRIs have some side effects, which we see mostly in children. Activation is very common in childhood, so it causes some activity in the child, and after SSRI, parents may complain that the child has become very active. And if that is the case, then changing of the dose might be recommended. Or if this risk causes other problems, then Phentermine could be added to the treatment. That is one of the recommendations. It is effective sometimes. Also, when we look at the use of SSRI use, bipolar switches are very uncommon, and it has a very late onset when it occurs. We see that frontal lobe symptoms might occur at higher doses, and we usually see a lot of gastrointestinal system side effects, and also easy bruising and bloody nose are also side effects that can be seen during the use of SSRIs. And there are also some case reports about affecting growth, but we don't have a lot of data, or let's say the data is very limited with regard to the effect of this. Now, what can be done for activation? So how can the medication be more effective? Psychoeducation is of huge importance. So telling the kids what is the treatment, and also activation of diphenhydramine might be a good option here for altering or adjusting doses if necessary. So sometimes late activation may occur, and it might be that it could be probably unrecognized, or it might be related to the dose that we have administered. So we should not really think, okay, this was not very effective, so I have to change this medicine. That's not the way we should think. So we have to take a look into the potential effects, side effects that could intensify the situation in the child. Because we don't really have that much choice anyway. So we have to be wise when we choose among the options that we have. So what to do for further activation? With regard to the efficacy of evidence that is not an antidepressant, we don't have data. So bupropion is not recommended during childhood, and for anxiety disorders, benzodiazepine is not recommended for anxiety in children due to side effects and the risk of addiction. And as far as I have seen in practice in Turkey, antipsychotics are used a lot in Turkey. They're actually used as if they're anti-anxiety drugs in Turkey, but the studies show otherwise. So antipsychotics are not recommended. And also alpha agonists are not deemed effective. So what should we do when SSRI doesn't have any effect? If we have also tried the highest safe dose, then we could move into another SSRI, or we could choose another group of medicine. So what about the non-activating antidepressants? We're talking about mirtazapine, duloxetine. By the way, we have all of these medications in Turkey. Maybe we don't have two of them. But please keep in mind that most of these drugs are off-label and are not valid or are not confirmed for childhood. But as in most cases, with regard to anxiety disorder, we end up having to use off-label for children, even if the safety tests have not been measured for children, because the number of trials we have is very limited. So for SSRIs, we have an FDA approval for 1 or 2 SSRIs, so we have to make sure that we're making the wisest choice. What about enhancing the response to treatment? We should not disrupt the pattern of treatment. We should not disrupt the psychotherapy, and adding psychotherapy or adjusting the dose might be an option. Adding a new medication might work for augmentation. And also intensive psychotherapy with including the parent might really work, especially in adolescents. Or you could completely change the SSRI if none of these above work. Now, also for enhancing the response to treatment, in terms of what can we add, there are some trials, and it shows that clomipramine was added for augmentation of SSRIs. You know that clomipramine has a lot of high risk of adverse effects, and clomipramine is added in low dose to SSRI because it has some genetic and pharmacodynamic interactions, and if the dose is high, it might have a lot of severe additive effects. So the side effects need to be monitored when clomipramine is added to the treatment. One of the key reasons for not preferring clomipramine most of the time is it causes some side effects such as high blood pressure and also pulse, tachycardia, BP need to be followed up, and even ECG might be required. I'm not sure if we have this. Do we have IV clomipramine in our market now in Turkey? Anyone? I think we had in the past, but I'm not sure about it now. IV clomipramine is a very potent agent, and remember, clomipramine was one of the agents that was confirmed or approved the latest by FDA. So intravenous clomipramine might be added in some cases, and it's a very potent serotonergic agent, and it's a very strong noradrenergic agent as well. So to improve the serotogenic effect, we prefer to administer it intravenously, because if it's administered intravenously, it doesn't move into the liver, it bypasses the liver. Especially for resistant OCD cases, it is preferred, and sometimes it can be combined with low-dose fluoxamine in very resistant cases. What about enhancing or augmentation with risperidone? As I said, in controlled trials, it suggests that antipsychotics can be quite useful for schizotypy or related OCDs and tics. Maybe because behaviors are more in common with tics and repetitive behaviors than the classic OCD cases. And it's also good for anxiety and mood disorders, but some trials suggest that there might be worsening of OCD by risperidone. Adding a second SSRI without changing the medication seems like a logical option. Pharmacokinetic and pharmacodynamic interactions really need to be analyzed thoroughly, and most patients can tolerate both medications, and using short half-life SSRI and long half-life SSRIs might enhance the therapy, obviously by setting or adjusting the dose very carefully, considering pharmacokinetic and pharmacodynamic interactions. Now, lithium augmentation is recommended for adult patients. There's no such controlled trial for childhood, but if we're talking about comorbid depression with anxiety disorder, then it can be used. Adding buspirone is not supported with controlled trials for children. There are some trials or some, let's say, articles by some authors that support this, but there's still lack of support from controlled trials. Some clinicians defend this idea, but maybe we could talk about high doses. Maybe we're using low doses that doesn't show any effect. And there's also a discussion that saying that is there a small subgroup of patients who respond to this enhanced treatment, because we don't see the same effect in all patients. What about stimulant augmentation? If talking about a comorbidity and if there's apathy, it's useful. So more than anxiety, we're talking about mood disorders. We don't have some of these medications in Turkey. Now, all these additional therapies, so let's say some of these additional therapies are not or have not been researched in controlled trials in children, so there are some gray areas there. Clonazepam is an area, and clonazepam can be added to enhance the response. This is not augmentation, but it's more like adjunctive treatment. And there's a very famous trial by Svedo and colleagues, but it has very long dose assessment periods, and development of intolerance is very high. And we see that beta blockers might be added to serotonin agents when we're talking about performance anxiety in children, might be of importance. And we also see that, I did not write it down here, but we have some very frequently used herbal drugs such as passiflora. They are not effective, and they're not recommended to be used in children due to other side effects. Now, important issues we need to take into account in treatment. Now, one of them, in anxiety disorders, parents should be included in the treatment for childhood and adolescence, as patients don't really know what to do, and what they actually do is they feel desperate, and they instinctively end up supporting the child's avoidance acts, and they actually adapt to the anxiety rather than dealing with it. So the child asks, is there a monster under the bed? And the mother goes down and says no, and it becomes a ritual. Or are the windows shut? They just go and control it one by one. So this actually might morph into OCD after some time. For the child to change, the parents need to be involved in the process, and their support is vital. If they don't or cannot support the child, then the parents or the family should be sent to further therapy. Because the genetic anxiety disorder is also genetically has a very high rate of tendency. So mostly in mothers, the risk of prevalence of anxiety disorder is high, and due to mothers' very own anxiety, they end up encouraging the anxiety of the child. And that, what I do is I prefer to direct or refer the mother or the family to further treatment, explaining that you also need to take or receive support to make sure that your child copes with anxiety. So they end up, or they stop actually instinctively encouraging the anxiety, and the whole process becomes far easier. Now, integrating the child to treatment is also crucial. Therefore, we shouldn't really think that, okay, the child is probably treated, the family is in the process now, so that's it. No, that's not. We have to make sure that we detect the factors affecting the children negatively, and we need to make sure what positive steps can support the child with regard to treatment of anxiety. And if you're not applying a regular cognitive therapy session, or due to the age of the child, listing the stimulants that trigger the anxiety or anxious situations could be done, and desensitization from easy to hard could be attempted depending on the age of the child. With regard to treatment, I'd like to make a brief summary. Step 1, okay, we diagnose the patient, we've done what we could, and if the symptoms are severe, then we start with medications. Now, start with CBT when symptoms are of milder nature or of shorter duration. Start with combined therapy if available, and if the best outcome is required, that is obviously when the child can adapt to treatment. And if absolutely no response to step 1, then we could be talking about evaluating the assessment of adherence and adaptation to treatment. So we have to self-reflect, so to speak. In step 2, if we make it this far, if there is partial response or not very favorable in step 1, then we have to make sure that we check our dose of medication, and we have to adjust and perhaps maximize the medication using the highest safe dose available. Now, adding another medicine might be an option if that doesn't work. Or thinking about combined therapy here is also crucial. Even if we apply combined therapy, and if the effect is still not as desired, then the functions of anxiety, symptoms of anxiety rather, need to be re-evaluated. In step 3, if we're talking about tics or sensory motor symptoms or schizotypia, if these are the reasons that hold us back, then we could add antipsychotics to the treatment. If not, we could add serotonergic agonists. And if we're talking about obsessive compulsive disorder in these patients, a second SSRI might be a good choice. If we're talking about anxiety plus depression, or let's say depression and OCD, or vice versa, if we go through all these steps and if we still have problems in treatment, then lithium could be added, and other serotonergic agonists might also be considered. I think we have time for questions now. That's my presentation.